Okay, so today we're going to talk about something that I'm very passionate about. It's about the pregnant and postpartum pelvis. My personal feeling is that the sacroiliac joints and the pelvis itself is ignored way too often, that we see issues coming through in the lumbar spine. And my feeling is that so much of what is driving that lumbar spine pain is coming from the pelvic area. This is particularly important, of course, to anybody who's pregnant or has had children. As we'll hear in my little presentation, you know, the effects of pregnancy can last for a very, very long time into the future. And I think it's an area where we can be treating issues for many, many years into the future because they haven't been addressed sufficiently during or immediately after pregnancy.
Yeah. So while we're talking about the innominates and the symphysis pubis, I want to show you on this adorable little model here. This is what happens in normal walking. So as we translate forward, as the stride comes forward, the innominate rotates backwards. I'll show you. So as we come forward, the innominate is rotating in a backward direction. As I bring my weight forward over that foot, the innominate is rotating forward. So this is literally what's happening when we're walking. So that is physiological movement. However, when we get dysfunctions like this, we can get stuck in a certain position. And it's very common, as we saw with Trish, that we'll have an anteriorly rotated innominate, which fits in with the other things that we found going on in the sacroiliac joint. So if we've got a forward rotation of that innominate, it makes sense that at the pubic rami, we're going to have an inferior and a posterior displacement of that right side of the innominate. If the dysfunction's on the other side and we've got the same orientation, we've got a posteriorly rotated innominate, we've got a superior and an anterior pubic ramus on that side. So let's have a look at the ways that we might address that. So remember before we talked about that difference of how someone's going to look in standing compared to how they're going to look in prone when they've got what other people would describe as a leg length discrepancy. So basically, if the patient is lying down, this is where we're going to observe the difference in the left and right QL. And of course, if you can see from there, Trish is quite lifted up on this side. So what looked like this was the lower side when she was in standing is in fact the higher side here. And one way that we can prove that is come down onto the sit bones or the ischial tuberosities. When we look at the difference between left and right, this one's considerably closer to her head than this one is. So we know that she has an upslip on this side, okay? Downslips are also a thing, but a downslip is very traumatic, and in 36 years of treating this sort of stuff, I've seen 2 downslips ever. One was a guy who'd fallen off a horse and got his foot caught in the stirrup and got dragged along. The other one was a lady who was walking along the city street and got her heel caught in a grate. So as she kept moving, the leg stayed behind her and she had a traumatic downslip. These are adaptive, they don't tend to be terribly uncomfortable, and they can be easily treated. A downslip is excruciatingly painful. A patient has terrible difficulty with walking, but a lot of people will have an upslip and they won't even be aware of it. So what are we going to do about an upslip? We've got a couple of really, really nice techniques that I'd like to use. So in every physio's toolkit, we have a seat belt. And this can work really nicely as a means of saving your strength and maintaining your longevity in terms of your career, but also your capacity to do your job throughout the day. So a really nice way to use this, and there's absolutely no reason, even as a movement therapist, that you couldn't do this with a patient, is just make your little figure 8 and hold your hands within that, because you don't want the strap rubbing against the patient's skin. So what I would do is feed her foot inside of there. Now what are my instructions going to be? As I traction her down, I am elongating that QL on that right hand side. And what I want her to do is activate just the QL. Patients will cheat and use every single other muscle that they've got, but we want to isolate QL. So what I might have to do is take her through a little bit of a test first. If this has been an issue for a period of time, what I find over and over is people just can't find the QL. They'll look and look and look, they'll fire everything else, but they won't get this muscle. So often we need to give them a little bit of tactile feedback. Okay, so Trish, what I'm going to ask you to do is imagine you're shortening your waist on this side using just this muscle. Try that for me. Good. Okay, so she can actually do that quite nicely. So she's got that movement pattern in her head now. Let's go back down to here. Get some traction onto that. Now make sure that the patient isn't working as you're applying your traction. So I'm literally pulling down on that side and I'm using the belt so that I don't have to exhaust my arms to do that. Against that traction, what I'm then going to ask her to do is exactly what she's just done for me and hitch the hip up towards the rib cage. So now she's firing QL in a lengthened position, which has the effect of making it relax. In other words, it inhibits that QL.